Very good evening, Demsonians. Is it audio video fine? Kindly write in the chat box. Is the audio video fine? Very good evening, everyone. Kindly update in the chat box. Is the audio fine? Audio, video, everything is fine. Can we start with the ENT session? Everyone, please kindly update in the chat box. Is the audio video fine? Can we start with the session? Yes, kindly comment in the chat box. We can start. Is the audio video fine? Very good evening, everyone. Yes. So dear Demsonians, I will be trying my best to concise the whole ENT in the upcoming 30 to 40 minutes. I will be telling you all the expected MCQs, all the expected topics. No need of writing anything. Take my words, everything is in your class notes, but I want to just make you realize which are the important topic, which are the worth remembering points, I will be starting from the topic of ear. Everyone, listen, appreciate the keywords better. No need of writing anything. So your NEET examiner, they can ask you the MCQ on incision. So always remember the first incision which I am showing you is your Rosen incision, R-O-S-E-N. Rosen, used for autosclerosis, beta. Always remember this is known as endomeatal. We call it as endomeatal incision. Then there is one Lempert incision, what we call it as Lempert incision at the incisor terminalis. Lempert. So what is the important point, everyone, every student? What is the important point regarding Lempert? What your NEET examiner will make the MCQ? It is used for pediatric patient. Yes, one point. It is used for pediatric patient. It is known as end oral incision. Am I understandable? So Lempert incision. One is your post-auricular incision. Behind the pinna is post-auricular, named by the name of Wilde incision. So mastoid, it is used for mastoid surgery. Am I understandable? So I just want to highlight three important incisions. One is endomeatal, one is your end oral, one is post-auricular incision. What expected, like we are expecting integrated MCQs. So out of 200 MCQs, they can ask you the importance of post-oral. They can ask you importance of post-oral incision in pediatric population. So always remember, in pediatric, we never extend to the lower edge. We never extend up to the lower edge. Why? Because facial nerve can be damaged. Clear? Coming to the next point, just concentrate. Is it running fine? Now, if the examiner give you a history, please kindly exit. If the examiner give you a history of ear obstruction, young patient, bilateral condition, is a growth abnormality, bilateral condition, growth abnormality. There is an obstruction in the external auditory canal. Bilateral, it is age somewhere 5 to 20 years. What we call it as, we use a word keratosis obturans. We call it as keratosis obturans. We use the word keratosis obturans. What is the worth remembering point? In this topic, there is no necrosis. So if there is a necrosis, cholestroma of the external auditory canal. Make a diagnosis of cholestroma of the canal. Am I understandable? So this is keratosis obturans, worth remembering point, growth, bilateral, young patient. If the examiner give you this type of history, there is a ear discharge, redness on the pinna, we label it as diffuse otitis externa. Different books, different synonyms. It may be known as swimmer's ear, telephonic ear, Singapore ear, tropical ear. Four important one-liners for diffuse otitis externa. Clear? Next slide. I am giving you ear discharge. Just appreciate the keywords. First keyword in MCQ, diabetic patient. There is a pus in the external auditory canal. There is granulation in the canal. There is a facial palsy. Patient is diabetic. What we are using the word malignant otitis externa. MCQ mandatory beta. This question will be there in your upcoming NEET examination. So be confident of all these points related with malignant otitis externa. Technetium 99 for diagnosis, gallium is for prognosis. Always remember, gallium is for prognosis, but patient is very poor. So what we use? We use ESR. ESR. What is a golden important statement which I always share in my regular batch lectures? Malignant otitis externa, mean years, the treatment is medical treatment. Always remember, treatment is medical treatment. We will go for NT. Which bacteria we suspect in this malignant otitis externa is your malignant otitis externa is your Pseudomonas. So we will go for third generation cephalosporin. Beta Priya, necrotic lesions. There will be necrotic lesions. I will be showing you necrotic. There will be necrotic lesions, or the word necrosis will be there. Dr. Priya, how to differentiate cholestroma from? I will be showing you. But just remember, if the word necrosis mentioned, clear? Malignant otitis externa, mean year, Pseudomonas, cephalosporin, third generation cephalosporin. Then we will go for debridement. Clear? Next slide. I am dedicating to a school-going child, young age, serous otitis media. But what should be there in MCQ? Always remember, in the MCQ there should be no fever. But a clinical vignette they will be providing you. In that clinical vignette, just remember one point, everyone. Just remember, very good, very nice response. Dr. Anjana, it is Pseudomonas. Just remember, if there is no fever, no serous otitis media. What is the treatment? We will be going for myringotomy. I will be going for myringotomy. In which quadrant? We will be going in anterior-inferior quadrant. But if my patient is not responding, for 3 months, I will go for grommet. Where I will insert the grommet? Always remember, keyword anterior-inferior. Next point, if the same age presentation, everything is same, but high grade fever. If high grade fever is mentioned, I will go for ASOM. If high grade fever mentioned, I will go for acute suppurative otitis media. Which bacteria? Sir, Streptococci. Which bacteria? Streptococci. Clear? So Streptococci. Dr. Shabul, keratosis obturans management will be, we have to remove the squamous cell. From external auditory canal with acetic acid. But if the patient is not responding, we can go for canaloplasty. Just beta, please kindly refresh. It's absolutely fine from our side. So ASOM, acute suppurative otitis media. Pseudomonas is Streptococci is there. In ASOM, always remember, it is your cartwheel appearance. We will be having cartwheel appearance. Or lighthouse sign. Cartwheel appearance will be in pre-suppuration. Lighthouse sign will be in the stage of suppuration. Kindly respond in the chat box. We will be starting from the topic of AFM. I hope now everything will be fine. Please beta, sorry for the delay. High grade fever. Just remember the keyword will be high fever. Appearance, pre-suppuration. A lighthouse sign, if the examiner asks you lighthouse sign, stage of suppuration. Just remember what is the key point. Key point is in ASOM. We will not be putting any grommet. What is the treatment? Treatment will be myringotomy, but we will be going for circumferential incision in posterior inferior. Now, what is the other keyword? The next keyword after ASOM, acute suppurative otitis media. Just remember, if there is a perforation with no foul smelling. What is the keyword? Beta, ध्यान से सुनेंगे. No foul smelling. There is no blood stain discharge. No foul smelling, no blood stain discharge. I label the patient as safe ear. We call it as tubotympanic ear. Better listen the keyword. I'm highlighting the keyword. If the patient is having the perforation but there is no foul smelling, we will label the patient as tubotympanic ear. We will do what is the treatment for tubotympanic ear? We will be going for tympanoplasty. What is the treatment for safe CSM? Safe CSM, we will be going for tympanoplasty with OCR. Ossicular chain reconstruction. So treatment for tubotympanic ear will be tympanoplasty with OCR. Coming on the next image, if the examiners show you there is a perforation, in actic region, there is a perforation in the upper part, the foul swelling discharge, there is a blood stain discharge, there is a granulation, we label the patient as acticoantral ear. We label the patient as unsafe ear. Just remember this point. We label the patient as unsafe ear. Blood stain discharge, foul smelling. Again, listen the keywords. In the MCQ, they will be giving you 40-year-old male complaining of chronic ear discharge, blood stain, there is a foul smelling, there is a granulation, there is a perforation in the part flaccida. Can you appreciate in the image? There is a perforation in the part flaccida. We call it as acticoantral ear. What is the treatment? Treatment is modified radical mastectomy. Beta, every Damsonian, very sorry for the interruption. There was some network issue. Now I am trying my best to highlight all the keywords. Please focus. No need of writing anything. Every point is in your class notes, but these are the worth remembering point. Everyone just focus. If the examiner compare this condition with the second condition, same scenario, everything same, but there is a pain in the history. In the examination, there is a pain. The patient is complaining of severe pain. Always remember a golden statement for Central Institute. Always remember one important statement. If pain is there, we should rethink the diagnosis of CSOM, chronic suppurative otitis media. Yes, beta, every student, I will be doing in the very fast mode. The first image I have shown you, serous otitis media. There is no fever, no congestion, there is bulging tympanic membrane. What we will do? I will do laryngotomy where anterior-inferior. If patient not responding after 3 months, I will be going for grommet insertion. Now, if there is a high-grade fever, ASM, streptococci, cartwheel appearance, pre-suppuration, lighthouse sign, suppuration. No grommet, but circumferential laryngotomy. Perforation with no foul swelling discharge, no blood stain, no granulation. We label the patient as tubotympanic ear. But I am starting from the beginning, just concentrate. We call it as safe ear. We call it as tubotympanic ear. Listen, beta, everyone, we will not miss anything. As a part of DAMS family, we promise you, we will not miss anything. Just focus. Treatment, tympanoplasty with OCR, ossicular chain reconstruction. PORP, partial ossicular replacement, total, everything in the class notes. Now then, I taught you the concept. If blood stain discharge is there, foul swelling is there, granulation is there, part flaccida is involved, I label the patient as acticoantral ear, unsafe ear. What is the treatment? Modified radical mastectomy. But if pain is there, always remember, pain, we will go for malignancy. And what is the treatment for malignancy? Everyone, this question is expected. No pain, unsafe ear. Pain, malignancy. Which treatment? Radical mastectomy. Next slide, very crucial for upcoming examination. There will be a history of trauma. 5-year-old child or maybe 30-year-old, age distribution is not there. But if there is a trauma, on tympanic membrane, you will be having traumatic perforation. What is the key word? Wait and watch is the treatment, beta. There will be a clinical vignette, long history, but MCQ will be on wait and watch. They will be giving you option. Which of the following is a false statement? They will give antibiotics, eardrop is the treatment of choice. That is a false statement. It means what is the key word on which the examiner will make the MCQ, beta. Always examiner के emotions को समझना है. Wait and watch for 3 months is the treatment. Always keep ear dry. Next point, a female complaining of hearing loss, pulsatile tinnitus. Beta, this word mentioned. Pulsatile tinnitus, hearing loss, female. we will go for glomus tumor. Hearing loss, female, pregnancy, I will go for otosclerosis. Just try to remember how to differentiate. Just remember, beta, every student focus on the keyword. Hearing loss, pulsatile tinnitus, female, glomus tumor. Hearing loss, pregnant female, young female, I will go for otosclerosis. In both the condition, beta, tympanic membrane will be red. In glomus tumor, it is rising sun sign. In otosclerosis, it is short sign. In otosclerosis, short sign. Focus on keyword. I promise you, beta, on this platform, none of the MCQ of ENT will be beyond these points. Just listen carefully, each and every word. Hearing loss, pulsatile tinnitus, rising sun sign, blanching, B for brown sign. We will go for glomus tumor, but the rising sun sign in otosclerosis, it is short sign. Rising sun sign, red tympanic membrane, but there will be a bulging of the tympanic membrane. But in otosclerosis, there will be no bulging. But one of the student is asking, Dr. Salfa, this pain also no, never. Always remember, chronic subperioral iris media, pain should be ruled out. Pain should not be there. Clear? This is your glomus tumor treatment, surgery. Next, these are the important symbol, beta. In your NEET examination, they will ask you a symbol. The favorite is your cross. They will be asking you left side air conduction. So I expect all the symbols should be on your tips. All the symbols should be on your tips. Coming on the next one, audiogram. They will be showing you air-bone gap. Can you appreciate between air conduction, bone conduction? There is a big gap. How much big? Expected MCQ for NEET examination, beta? I am not the examiner, but we expect this year MCQ will be there. Air-bone gap is defined as loss more than 15 decibel. Loss more than 15 decibel. If there is a hearing loss of 60 to 70 decibel, no air-bone gap. I will label it as sensory neural. What is the difference? Moderate is sensory, severe is neural. Moderate is sensory, severe is neural. They can pick one MCQ for you. Next MCQ, favorite of your NEET examiner, 2000 Hertz. If examiner give you anything in the 2000 Hertz, always remember it is your otosclerosis. And what is the emotion? Examiner की emotions क्या है? उसकी भावना क्या है? Bone conduction. वो किस पे question बनाएगा? He will make an MCQ on bone conduction. Heart notch, feature of bone conduction. Expected MCQ, otosclerosis. Which is the important foci? Anterior focus, posterior focus. It is known as fistulae antifenestrum. So anterior foci. Always remember. What is the drug of choice? Sodium fluoride. But short sign positive. Will I go for surgery? Not at all. If short sign positive, it is a contraindication for surgery. But which surgery you prefer? You will go for stepidotomy or you will go for stapedectomy. Just remember, stepidotomy is a treatment of choice. Stapedectomy is a treatment of choice. Heart notch, bone conduction, pregnant female, go for otosclerosis. If you are my student, beta, ENT MCQ, pregnancy mentioned, don't waste your time. In ear, it will be your otosclerosis. In nose, it will be pregnancy granuloma. I will be teaching you tympanograms. Yes, all tympanograms should be on your tips. This is not the time to go in the detail of these tympanogram. But yes, what is A? Normal. What is B? Flat tympanogram, which is seen in the fluids. Type C, ET dysfunction, eustachian tube dysfunction, hypomobile is AS. In otosclerosis, you will be getting AS tympanogram. If it is hypomobile, like ossicular damage, what you will be getting? You will be getting type AD. Each and every word is a potential MCQ. Instead of 2000, they are showing 4000. What is this one? This is noise-induced hearing loss. Which MCQ? Outer hair cell is involved. What is the criteria? WHO 85 decibel, mnemonic 85 decibel, 85, 8 hours in a day, 5 days in a week. So 85 decibel, maximum limit 8 hours in a day, 5 days in a week. But Indian Factory Act, WHO guideline 85. Our guideline, we people, easygoing people, relaxed people, will go for 90 decibel. Am I understandable? I am showing you the slide. Next slide. A male. Just appreciate the keywords. What will be the keyword? 30 to 40 year age of male. Unilateral fluctuating hearing loss. fluctuating hearing loss. There is oral fullness, vertigo, tinnitus. Don't waste your time. In the Landy history, the patient is Meniere's patient. M for male, Meniere's patient. M for medical treatment. Female, otosclerosis. S for surgery. What is the investigation of choice? Electrocochleography, beta. Electrocochleography. But before electrocochleography, you will be doing PTA, pure tone audiogram. What you will be seeing? Sir, I will be seeing rising curve. Graph going up, rising curve, down sloping graph, press bicusis, rising curve, Meniere's, everything in class notes, gold standard DAMS class notes. This is a expected MCQ. Every student focus. The flowchart should be on your tips. Once you diagnose you confirm the diagnosis of Meniere's, then we will go for dietary modification. Dietary modification, beta, everyone close your eyes, listen my word. Dietary modification, 90% success rate. But if the patient not responding, I can go for diuretics. But if acute attack is there, I can go for intratympanic steroid. If treatment failure, I will go for PPT, positive pressure therapy. Every damn student listen carefully. If PPT fails, if positive pressure fails, I will go for surgery. And if even the surgery, which surgery? Endolymphatic sac decompression. And even if the surgery fail, I will go for destructive procedure, that is gentamicin, intratympanic injection of gentamicin with the help of a device known as microwick. All are keywords. We people nowadays, we are not performing neurectomies, labyrinthectomy, destructive procedure. So examiner can ask you the last question was, one of the students is asking if nothing is mentioned, what we should mark, 85 or 90, beta, they will mention, but if they have not mentioned, go for WHO, that is 85. One of the students is asking what to mention if they don't specify WHO or Indian Factory Act. Last aims, they have asked you one question, patient vertigo is not responding to basic medical treatment. What is the next option? We will go for endolymphatic sac search, not responding, gentamicin. If patient is not even responding to endolymphatic sac decompression, we'll go for gentamicin, beta. Just remember this concept. Just focus your eyes on this quotation. Decent rank, while will to win, desire to succeed is required, beta. What is the keyword? Desire and urge. In the last spell, beta, work hard 24/7, and every faculty is with you, beta. None of these would have expected in the last spell. We are coming with this new concept of must-read topics, beta. And hats off to Dr. Sumer with these innovative ideas. Have faith on us. Single source, multiple revision, decent rank waiting for you. Keyword, remember, desire, urge should be there. Yes, what I'm showing you, 60-year-old patient, unilateral sensorineural hearing loss, 60-year-old, always suspect tumor, unilateral sensorineural hearing loss, tinnitus is there, neurological symptoms are there. Once neurological symptoms are there, I label the patient as acoustic neuroma. What is the keyword in the MCQ? They will show you this type of appearance. Yes, very nice. Which ice cream? Ice cone appearance at CP angle, cerebropontine angle, ice cone appearance. We will label the patient as acoustic neuroma. What is the treatment? Before treatment, I will be telling you the investigation. Yes, sir, I will be doing better. But once the diagnosis is confirmed, I will be going for surgery. If patient deny, gamma knife radiotherapy. So what is required in the last spell, beta? Remember, greater age more than 60, unilateral sensorineural hearing loss, tinnitus, neurological symptoms, ice cone appearance, go for surgery, patient deny, gamma knives radiotherapy. 1 minute for glomus tumor topic should be over. Beta, expected MCQ, beta, please highlight this topic. This topic will be there. Beta, 7 waves are there. What is the mnemonic? Mnemonic is ECOLI. 8 nerve, cochlear nucleus, olivary, lateral hemisphere, inferior colliculus, medial geniculate, auditory cortex. For medial geniculate, auditory cortex, we have SARA, cortical evoke response audiometry. For the first 5 milestones, we have beta. But I have seen one MCQ in one of the recent examination where they use a word trapezoid body. So just remember the word trapezoid body. If the trapezoid body is there, it is between cochlear nucleus and olivary complex. Trapezoid body is the area where all the fiber cross. So trapezoid body is between C and O. C and O. Never get -1 in this MCQ. Clear? Then there is a keyword, mild vertigo. Mild vertigo means few seconds. Second vertigo for 5 to 10 seconds. Just remember this point. Positional, gamma knife beta. Gamma knife, we prefer gamma knife. Mild vertigo, positional vertigo. Examiner will give a lengthy MCQ, long history, long choices. One choice will be vertigo lasting for half an hour. Never make a diagnosis of benign paroxysmal positional vertigo. The word benign itself is telling you mild vertigo. Few seconds in a position, but what is the keyword? No hearing loss beta. Mild vertigo, no hearing loss. I will make the patient sit, then I will rotate the head of the patient, then I make him or her supine, what we call it as Hall pick maneuver. Investigation of choice, Hall pick, same circle. If I rotate, the whole exercise known as apply. Better just remember last AIMS examination, they give the whole clinical history. They ask investigation of choice, Hall pick. Treatment of choice, apply. Hall pick is nothing but first 2 steps of the Apply's maneuver. Clear? So BPV, very important topic. One important segment, OAE, auto acoustic emission. Screening procedure of choice is by outer hair cell. Which OAE is best? Transient evoke OAE is best. Reference DAMS gold standard class notes. Clear? Next, coming to the next one. Yeah, what I am showing you, old man, BTE, behind the ear. I am teaching you some hearing aids. Rehabilitation of the patient. Just remember behind the pinna, BTE. Extremity of age. Every student, close your eyes, listen the word. Extremity of age. Pediatric patient, old patient. BTE. Pediatric patient, old patient. Then they can ask you the full form of CIC. Completely in the canal. ITE. In the ear, ITE in the ear. If any of the student is feeling we are moving fast, beta, this is the need of R. The speed at which I am teaching you, you should proceed, beta. If the patient is suffering from conductive deafness, I will invest treatment of choice, hearing aid. If the patient is suffering from sensory deafness, neural deafness, what is the first treatment? Hearing aid. Just remember, conductive deafness, treatment of choice, hearing aid. Sensory deafness, neural deafness, what is the first treatment? Hearing aid. But what is the treatment of choice? If the examiner asks you treatment of choice, it is cochlear implant for sensory deafness and brainstem implant for neural deafness. Everything is same. What is the difference? Every damn student should reply in the chat box. What is the difference between cochlear implant, brainstem implant? Layman language, sir. Electrode की length का difference है. In cochlear implant, we keep in scala tympani. In brainstem implant, we keep in lateral recess of fourth ventricle. Everything is same. But you people should be confident of 2 frequently asked MCQ, which is the most common complication. Mondini dysplasia indication, which is a contraindication. Mitral aplasia. We insert in scala tympani via round window. Am I understandable? These are the points of cochlear implant. Brainstem implant, we keep in lateral recess of fourth ventricle. Yes. Now examiner is giving you history of trauma. Surgical trauma. Yes. Maybe physical trauma, surgical trauma. Followed by vertigo, nystagmus, by loud noises. Yes, one image is given. In that image there is some dehiscence, what we label it as, we call it as superior semicircular canal dehiscence syndrome. Worth remembering point, beta. Just remember keywords: trauma, vertigo, nystagmus. There will be neurological symptoms. Yes, there will be neurological symptom. Why? Because unwanted sound is going via dehiscent area into the brain. Neurological symptom with conductive deafness. MCQ examiner की भावना यहाँ पे conductive deafness. He will write a statement, sensory neural, false statement. It is conductive deafness. Then they will ask you investigation of choice. What is investigation of choice? Sir, VEMP, vestibular evoke myogenic potential. VEMP for vestibular lesions. Audiometry for cochlear lesion. So investigation of choice is vestibular evoked myogenic potential. Kindly respond in the chat box. Everyone enjoying? Yes, this completes our first spell of ear. The MCQ expected from ear. Coming on larynx. Always remember, out of 10 MCQs of your NEET examiner, 6 MCQs will be coming from the topic of ear. The topics we some 3 topics. Then I am showing the line diagram, taking you to the dissection hall, cadaver, remove the larynx. You are standing behind larynx. Just focus your eyes. You are standing behind larynx. If you are standing behind larynx, beta, this is your base of tongue. And if this is your base of tongue, this is valvular. This is valvular. This is my larynx. Just remember one point, beta. Lateral to larynx is paraglottic space, and what is lateral to paraglottic space is piriform fossa. Larynx, lateral to larynx, paraglottic space, lateral to paraglottic space, piriform fossa. Piriform fossa visible, paraglottic space not visible. Therefore, we go for MRI CT examination. We go for MRI CT examination. Am I understandable? Absolutely. One of the students is writing handbird sign. Absolutely true. Clear? Coming on the next slide. Next slide. This is again an important image. They can ask you what is a vallicular. Just remember, vallicular pre-epiglottic space. Vallicular is above, pre-epiglottic space is below. Vallicular is above, pre-epiglottic space is below. Better just wait, refresh, everything is fine from our side. Vallicular pre-epiglottic space. Vallicular pre-epiglottic space. Just wait 1 second. Let me refresh. Yes, focus your eyes on the board. Every student. Yes, just I'm refreshing. Yes, wait for a few seconds. Beta, relax, relax, relax. Yes, vallicular is visible. Vallicular is visible. Vallicular is visible. Pre-epiglottic space is visible. Pre-epiglottic space is visible. Pre-epiglottic. Just wait, wait, wait. Now is it fine? Now is the audio video fine? Just concentrate, beta. Is the audio video fine? I'm refreshing. Give me 1 minute. Just give me 1 minute, beta. I'm refreshing. Yes, every student, now concentrate. I have refreshed the thing. Now after the topic, just wait, beta. Just wait. Now concentrate. We are restarting the things. I'm showing you one image. I'm showing you one image. I'm showing you one image of lateral view of larynx. Lateral view of larynx. Vallicular pre-epiglottic space. Vallicular pre-epiglottic space. Coming to the next slide. Yes, patient complaining of hoarseness. If patient is complaining of hoarseness, just remember 2 possibility. If it is unilateral lesion, it is your polyp. We give a mnemonic to our students. If it is unilateral polyp, we have to go for search. We will operate. Am I understandable? So if it is nodule, if it is bilateral, it is at the junction of 1/3, 2/3. Bilaterally, we label it as, we call it as, I'm starting from larynx, beta. Just wait, wait, wait. Clear? So it will be, if it is bilateral, we label the patient as nodule. We label the patient as nodule. Clear? So nodule, we will go for wait and watch. We go for wait and watch. Just concentrate. Beta, in ENT, 8 out of 10 MCQs, 5 to 6 will be coming from ear. Now focus your eyes. Yeah. If the examiner is giving you a history of high-grade fever, toxic patient, high-grade fever, inspiratory dyspnea, thumb sign positive, we call it as epiglottitis. We label the patient as epiglottitis. And if there is a low-grade fever, chronic chronic, we call it as croup. We label the patient as croup. Bronchitis, we call it as croup. Better just relax, listen. I will not miss a single point. High-grade fever, epiglottitis. Low-grade fever, we will go for croup. In croup, you will be getting stipple sign expected. MCQ, they will be asking you on the stipple sign, or they will be asking you the thumb sign. Epiglottitis, IV antibiotics, causative factor is streptococci, but in stipple sign croup, it is your para-influenza virus. Coming on the next slide. Yes, one of the most important MCQ have to be there. Age of distribution 3 to 5 years. Chronic hoarseness, dyspnea, may not be there, dyspnea may not be there. We label it as papillomatosis. Juvenile papillomatosis will be multiple, resolve, reoccur. Senile will be single. This image very crucial for your NEET examination. Just remember what is the treatment. Treatment is CO2 laser, is a pre-malignant condition. But we will promise you will not miss anything. Here I have taught you each and every point. Larynx, nose, we will discuss each and every point. Just relax. If there is some issue, beta, just cooperate for a few seconds. We are refreshing from our side. Red mass in subglottic area. What is the key word? Keyword is reddish mass in subglottic area. First 6 months, newborn having dyspnea, red mass in subglottic hemangiomas. What is the treatment? We have to operate. We will go for surgery. In hemangiomas, we will go for surgery. Am I understandable? We'll be going for surgery. Subglottic hemangioma. Next point is your subglottic hemangioma. Followed by, after subglottic hemangioma, if the examiner, now next condition very important, if the examiner is giving you a history of age more than 60 years, chronic smoker, chronic alcoholic, there is an involvement of surrounding areas. Listen carefully, beta. Listen the important keywords. Age more than 60 years, chronic smoker, alcoholic, involvement of surrounding areas, carcinoma, larynx, CA, larynx. TNM classification should be on your tips. Management should be on your tips. As far as the treatment is concerned, always remember T1, T2. Radiotherapy is the first line of treatment, always. But treatment of choice, I will discuss later on. T3, T4. Always remember T3, T4. Treatment is surgery plus radiotherapy. T1, T2 only radiotherapy. First line of treatment. But if the patient if my T3, T4 patient deny for surgery, I can go for concurrent chemoradiation. This is a basic funda. I am repeating again. T1, T2 radiotherapy. T3, T4 surgery plus radiotherapy. Patient deny, go for concurrent chemoradiation. Now coming back on T1, T2. If the radiotherapy is a first line of treatment, but if the examiner asks you the treatment of choice, keyword glottic tumors, radiotherapy, and supraglottic subglottic tumor, partial laryngectomy. And how many type of partial? Horizontal, vertical, cordectomy. HPL, horizontal is indicated for supraglottic tumors, vertical is indicated for hemilarynx tumor, and cordectomy is radio-resistant glottic tumor. Which is the expected MCQ for horizontal partial? What we do? Pulmonary function test. PFT is mandatory. Coming on the next, vocal rehabilitation. But out of these three, they will show you one. FMG, Provox. All the three are tracheoesophageal prosthesis. Always remember, important topic. Tracheostomy tube. What is the expected MCQ? How frequently we should deflate? Too early for 5 minutes. Cuff tube. What is the important point for cuff tube? High volume, low pressure. Should be there. If the examiner show you this type of tube, this is fenestrated tube for voice. Listen, everything will be there in the recorded form, beta. You can listen these points, keywords again. I'm just trying my best to give you the must read topic which are mandatory. If the examiner show you image in which there is one of the vocal cord paralyzed, we call it as important topic, vocal cord paralysis. Thyroplasties, Ishika classification should be on your tips. But one of the key word which I want to highlight, in all unilateral cases of vocal cord, paralysis, we prefer to wait and watch. I expect you people must have revised the notes. Type 1, type 2, type 3, type 4. What is medialization? What is lateralization? Medialization is for superior laryngeal palsy. Lateralization is for recurrent laryngeal palsy. I hope audio video fine on your side. Coming on the next one. Beta, this complete the important topic of vocal cord paralysis. I am again highlighting anatomy of larynx. One MCQ will be there. They will be comparing epiglottitis against croup. They will be comparing the Recurrent papillomatosis, polyp against nodule. One is your carcinoma larynx, management of carcinoma larynx, very important. Vocal cord paralysis, treatment of vocal cord paralysis, very crucial. One important topic which they will be covering in the pediatric section is your congenital dyspnea, that is laryngomalacia, congenital webs and subglottic stenosis. Beta, three important topics: congenital, laryngomalacia, webs and stenosis. Key point: hoarseness is in glottic segment. Inspiratory dyspnea, supraglottic segment. Glottic is biphasic with hoarseness, and subglottic is only biphasic dyspnea. And there is expiratory dyspnea in the lower respiratory tract. Beta. Now it's your choice whether you want to quit or you want to be a champion. And always remember, damn students are always champion. Never ever quit, beta. We are suffering, beta. This is hard time going, but I promise you, on the other side of the game, you will be the winner, you will be the champion, and this 1 year of preparation will help you, will take you to the next level of maturity, which helps you in the later part of your life. One MCQ or maximum 2 from expected from nose. I'm highlighting the important point: air cells, very crucial, beta. Most anterior, agonisi, most posterior, anodi. Which is the largest? Sir, bulla ethmodalis. And what is concha billosa? Concha billosa is your most common pathology of nasal cavity. Beta, if both superior recurrent laryngeal nerve, just this is one of the doctor, it is asking, if both superior laryngeal nerve, recurrent laryngeal nerve, which muscle will be spared? You tell me. That muscle which is unpaired muscle, na beta, interadditional, which have been bilateral nerve supply, it can be spared. This can be a tricky question. Concha billosa, most common pathology of nose. What is concha billosa? Middle turbinate, beta. Just try to appreciate. This is concha billosa, this is bulla ethmodalis. And what is this one? Lowermost cell. What is the lowermost cell? Is your Hallard cell. Hallard cell. Clear? Coming on the next one. Inferior turbinate hypertrophy. Mulberry-like nasal mucosa. Important topic, important points, worth remembering point. Thick peanut mucus. Mucin with brown cheesy material. Nasal obstruction. Foul smelling discharge. Headache. Hyperdense lesion on CT examination. Again, beta, close your eyes. Listen the keyword: thick peanut mucin with brownish cheesy material, nasal obstruction, foul smelling discharge, headache, neurological symptoms, hyperdense lesion on CT. Nothing but allergic fungal sinusitis. In nose, aspergillosis fumigatus. In ear, it is Niger. Three conditions to be compared: rhino, hypertrophy of sebaceous gland, rhinoscleroma. They will be crust formation, but woody nose. What is the keyword in the clinical vignette? 5-line MCQ: woody nose mention, carpenter glue mention, crust formation mention, rhinoscleroma. Which is other points? Miculicell, Russell body. Important point. What is the most closest diagnosis? Most closest diagnosis will be atrophic rhinitis. What is missing in the atrophic rhinitis? Sir, woody nose. Missing in atrophic rhinitis. Last, rhinosporiosis. What is the keyword? Keyword: mulberry-like nasal polyp. I am trying my best. These words will echo in your mind in the examination hall, beta. Be confident. Examiner will create a controversy on ethmoidal polyp and trochonal polyp. Just remember, ethmoidal polyp are bilateral and trochonal polyp are unilateral, and trochonal 10 to 14 years, ethmoidal 20 to 40 years. Ethmoidal allergy is predisposing factor, therefore reoccurrence is seen. Important point, NEET examination: reoccurrence, ethmoidal polyp. What is the investigation of choice? Sir, diagnostic endoscopy. What is the treatment of choice? FES. Both the patient investigation, all the complication of FES, what are the passes of FES, important for upcoming examination. Malignancy, 2 classification. Organs classification: medial canthus to angle of mandible, expected MCQ, upcoming NEET examination. Tumor below the line, good prognosis. Tumor above the line, poor prognosis. Second classification, sir, Ladderman classification. What is the horizontal line known as? Horizontal line known as lines of Sibylle. 4 important point, beta. All the students who, any student who have not revised ENT, just remember, 1 MCQ I am giving to you. Out of 4 concepts, 1 will be in your examination on 18th April. Most common benign tumor of nose, capillary hemangioma. Most common site, sir, litus area. Most common benign tumor of paranasal sinus, sir, osteoma, sir, on frontal sinus. Most common malignancy of nose, nose squamous cell carcinoma. Which site? Lateral wall of the nose. Most common malignancy of paranasal sinus, sir, squamous cell carcinoma. Again, on maxillary. Which patient? Sir, nickel industry. Which is second most common malignancy of PNS? Sir, adenocell carcinoma. Which sinus? Ethmoid, wood industry. I will be taking 1 more minute to repeat these points. Benign tumor of nose, capillary hemangioma. Benign tumor of PNS, osteoma. Malignancy, squamous in PNS, common in maxillary, but adeno, common in ethmoid. Which wood industry? Examination hall, sir, confuse हो गया, कुछ नहीं पता. Maxillary, nickel, MN, maxillary, nickel, always remember. Now focus. First three patient, concentrate. First three patient, treatment, surgery. Only one patient, malignancy of PNS, surgery plus radiotherapy. I expect you will never get confused. You will not confuse surgery plus radiotherapy for malignancy. One of the difficult topic I try to concise for you. Facial fracture, gingival fracture, horizontal fracture, chevalate, vertical fracture, on septum, horizontal, vertical gingival fracture, skull fracture, temporal bone fracture. Very important. So either they will ask you facial fracture or temporal bone. Very important. MCQ will be there. Longitudinal fracture, parietal trauma, they are more common. There is hemotympanum, there is ossicular damage, facial palsy is less. In transverse occipital trauma, it is vestibular symptoms. Facial palsy more common. Always remember. Difference between your temporal bone fracture. Dr. Pooja, thanks for the session. This is the need of hour. ऐसे भागना है बुलेट ट्रेन की तरह, अगर रैंक निकालनी है. अगर नहीं भागेंगे तो वेट करना पड़ेगा. वेट हम करना नहीं चाहते, रैंक हमने निकालनी है. लीफ फुट फ्रैक्चर, A, लीफ फुट 1, B, लीफ फुट 2, लीफ फुट 3, C. Which are the MCQ? A, low maxillary fracture, floating palate, urine sign. 3 MCQs. Low maxillary fracture, floating palate, urine sign. Leaf for 2, pyramidal fracture. Leaf for 3, craniofacial disjunction. Which 2 fracture? CSF rhinorrhea. Sir, leaf for 2 and 3. Which is more common? Sir, 3. इसके बाद leaf 4 से कोई question नहीं आता बेटा. This I expect from you in the last spell. 1 minute में leaf for 1. Low maxillary is equal to floating palate is equal to urine. Leaf for 2 is equal to pyramidal. Leaf for 3, craniofacial disjunction. CSF rhinorrhea 2 और 3. More in 3. इसके बाद कुछ भी पूछेंगे वो पोस्ट ग्रेजुएशन से बियॉन्ड पोस्ट ग्रेजुएशन. इसके अलावा कुछ भी पूछेंगे रैंक 1 को भी नहीं आएगा. तो वाई टू वरी? एम अंडरस्टैंडेबल. ज्यादा प्रेशर लेना नहीं है. नेक्स्ट what I am showing you, this is urine sign. What is urine sign? Floating palate. There is ecchymosis. There is ecchymosis over the palate. Ecchymosis over the palate. What I am showing you, sir, what is view? बच्चे का मुंह खोल दो. Pierce view. What is not visible? Sir, posterior ethmoid. What is most importantly visible? Sir, maxillary sinus. 4 questions हैं. No question beyond this point. What is view? Open mouth. Pierce view. Maxillary X-ray of choice. Posterior ethmoid not visible. Posterior ethmoid not visible. Caudal, everyone speak caudal, long face. If the examiner show you a long face, it is caudal view. Long face, caudal view. किसके लिए? Sir, frontal और ethmoid. इसके अलावा कोई क्वेश्चन नहीं आएगा. Caudal, long face. Waters, broader face. Waters, broader face. ये क्या दिखाया? There is a fracture on the roof of the nose. CSF rhinorrhea. जहां से start हुए वहीं पे complete. What is the cause? Sir, surgical trauma. What is the treatment? Wait and watch. Not responding. What is the treatment? Sir, surgery. Now try to appreciate. सर्जरी, एंडोस्कोपी. मैंने पेशेंट की एंडोस्कोपी की, मैंने रप्चर कर दिया, फिर वेट एंड वॉच किया, रिस्पॉन्डिंग किया, फिर एंडोस्कोपी. 2 बार पेशेंट आपके पास आ रहा है, आप ऑपरेट कर रहे हो. ट्रीटमेंट भी एंडोस्कोपी, कॉज भी एंडोस्कोपी, बट बीच में वेट एंड वॉच. आईवी एंटीबायोटिक्स दे देंगे. व्हाई? टू अवॉइड इंट्राक्रेनियल इन्फेक्शन. CSF rhinorrhea, cribriform plate. इसके अलावा कोई क्वेश्चन नहीं आएगा. Am I understandable? Yes, tonsil is pushed, but no neck swelling. Tonsil push, neck swelling नहीं है. Quinsy, neck swelling है. Parapharyngeal abscess. Just remember the keyword quinsy, peritonsillar abscess. Don't confuse with Quincke disease. What is Quincke? Edema over the palate. Edema over the palate. If tonsil is pushed, neck swelling, parapharyngeal abscess. Why it is important? Sir, it is the most common abscess. Very good. Up to hyoid bone, up to hyoid bone. Sir, कहाँ पे incision दोगे? Sir, incision along anterior surface of sternocleidomastoid. What is the differential diagnosis? Sir, retropharyngeal abscess. But retropharyngeal abscess, where you will give the incision? Sir, posterior surface of sternocleidomastoid. Parapharyngeal, anterior surface. Retro, posterior surface. Beta Priya, Pier's view is open mouth, waters with open mouth. Retropharyngeal abscess extend up to bifurcation of trachea. But क्या इसमें neck swelling होती है? नहीं, इसमें तो posterior pharyngeal wall पे swelling होती है. It is unilateral, bilateral. Sir, it is unilateral swelling. अगर bilateral होगी तो सर मैं prevertebral abscess. I will call it as prevertebral abscess. Parapharyngeal abscess, neck swelling. Listen, beta, everyone, close your eyes. Listen the words. 4 abscess. Peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess, prevertebral abscess. No neck swelling, only tonsil pushed. Sir, quinsy. Sir, neck swelling with tonsil push. Sir, parapharyngeal abscess. Sir, swelling on the posterior pharyngeal wall. Sir, 2 point mind में आते हैं. Either it can be retro or it can be prevertebral. How to differentiate? Unilateral, retro, bilateral, parapharyngeal, prevertebral. Retropharyngeal abscess extend up to bifurcation of trachea. Parapharyngeal abscess extend up to hyoid bone. Always remember this point. Next segment. Yes, what is this? Young boy coming to you. A reddish mass in the nose. Young boy bleeding. Epistaxis मतलब ही नहीं. Epistaxis करोगे, they can take your degree back. Why? Patient will die on table. No biopsy. Young boy bleeding, we call it as angiofibroma. Treatment, surgery. लेकिन इस बार 2021 में कौन सा क्वेश्चन आएगा? कौन सी आर्टरी इम्बोलाइज करते हैं? सर, इंटरनल मैक्सिलरी आर्टरी. All the students listening to me at 10 o'clock, listen the keywords in ENT examination. Only 3 arteries we embolize. Internal maxillary artery, angiofibroma. Epistaxis, sir, sphenopalatine artery, sir, glomus tumor, ascending pharyngeal, everything in the class notes. Internal maxillary artery, angiofibroma, epistaxis, sphenopalatine artery, glomus tumor, ascending pharyngeal artery. Sir, angiofibroma, 2 classifications should be on your tips. Fish classification, Radonsky classification. Fish, Radonsky, लिखना नहीं है. We have to keep this point in mind. Fish classification, Radonsky, very important. But if they show you a 60-year-old patient with unilateral cervical lymphadenopathy with glue ear, eustachian tube is blocked, force of Rosenmuller is involved, we have a Trotter's triad, we call it as nasopharyngeal carcinoma. Beta, just close your eyes, listen the word unilateral cervical lymphadenopathy, age 60 year, glue ear, go for nasopharyngeal carcinoma. Trotter's triad, glue ear with 5th and 10th nerve palsy. You have Gradnigo triad where you have 5th and 6th nerve palsy. T for Trotter, T for 10. T for Trotter, T for 10. Don't get confused. Trotter's method? No, it is not Trotter's method. It is Trotter's triad. Trotter's method in epistaxis, most important topic, which artery we embolize? Sphenopalatine artery. I promise you, beta, out of 10, 7 MCQs, 8 MCQs will be coming from this must read topic. If anything is beyond that, will be even the rank 1 will be uncomfortable. So why to waste your time? Everyone has a desire to win. Beta, हर कोई जीतना चाहता है, लेकिन damn students, they are desire to prepare. Therefore, they are sitting with me at 10 o'clock in the night. Thanks a lot for showing faith at this point of time. When you are sitting with DAMS faculty, when your exam are there in the last spell, you are sitting with us. It means you have immense faith on us. Thanks a lot. If any of the students feel my speed was on the higher side, I just assure you, beta, this is the need of our next few days. Let us work 24/7. Best of luck, very best of luck, and we are confident every Damsonian will be getting a decent rank. You will be getting a decent branch. Best of luck, and always feel proud to be a medico. Every day in the morning when you wake up, feel proud to be a medico. Thanks a lot listening to me. Thanks to Dr. Sumer for giving this opportunity, giving this platform to